Okay, so I was here already for 4 minutes and forgot to record this. So let me go back and tell you the quick things about that I didn't record since Macy just reminded me. Okay, so test number 5 on urinary system fluids and acid base will be, it'll open on the 22nd and it'll close on the 25th. So you have those days to take that. We will Kahoot for test number 5 Tuesday, so the 21st, after our lab. So so there's that too. And I'll probably, that'll be recorded as a separate thing, not with lab. Okay, so we're ready to go now. Okay. All right, so last time we left off starting to talk about dehydration, and so now we want to talk a little bit more about dehydration. So what does it really mean? Well, if our extracellular fluid contracts, so those different contractions that we had last week or week before that, whenever we did that. And in some of those cases, we're not just going to lose water out of the extracellular fluid, we can lose water out of the intracellular fluid as well. So let's say that our plasma interstitial fluid became highly osmotic, so very concentrated, a lot more solute in the extracellular fluid space. Then the water will get drawn out of all of the intracellular places and places where we don't want to lose water from. Okay, so one of the places that we would lose our water from would be our saliva. We would reduce our saliva production, which totally makes sense. And so then we would get sticky oral mucosa, cotton mouth. You know, your mouth is just totally dry during sympathetic stimulation. Obviously, we would get thirst. Dry fleshed skin, because we're going to reduce the amount of sweat that we're going to produce. And then we're going to get oliguria, which is decreased urine output or scant urine. Definitely during times of dehydration, we don't produce a lot of urine. So what is that going to do? That's going to lead to weight loss, because, you know, 60% of our body weight is due to water. But this is not the way that we want to lose weight. Like I was mentioning last time when we were talking about diuretics or sometime in the case of individuals suffering from anorexia or bulimia, it's not the way you want to lose weight. We're going to get fever. Now, fever not caused by pyrogens, not caused from an infection. This is going to be a fever because of elevated body temperature, because you can't cool yourself down. Okay, so fever is fever. Fever is elevated body temperature. How does it get caused? Well, multiple ways that you can elevate body temperature. But in this case, you're just not cooling yourself off. You're not evaporative cooling. Mental confusion and hypovolemic shock. So your brain's not getting everything, all the blood that it needs. And you're going to, your blood pressure is going to try to stay high for a while, and then it's just going to plummet, like we see in hypovolemia or hypovolemic shock. Okay, so we don't want those things to happen. But at the same time, we can suffer from too much water. So this is when the extracellular fluid is diluted. So we can really have it two ways, either too much water consumption, well, actually 3 ways: too much water consumption, renal insufficiency, and adrenal insufficiency. So if we're not producing aldosterone, if the adrenal cortex can't produce aldosterone, we may end up excreting more sodium than we want to. Make me another note for Friday. Okay. All right, and maybe alcohol consumption, ADH is inhibited, but we've got lots of water. Oh, whoops, I'm reading under normal conditions. I was going down to this one right here. Okay, so under normal conditions, when the CCF is diluted because of a deficiency of sodium sodium ions. ADH is inhibited, water is quickly flushed from the body. So under normal conditions, we get rid of that extra water. Okay, that's where I'm going with this. But like I just said, if we have renal insufficiency, too much water consumption, or like I said, adrenal insufficiency, but we won't make that part of our notes, but that's definitely a cause of hypotonic hydration, is if you have not enough aldosterone. So the ECF will be diluted, osmosis occurs into the cells, leads to metabolic disturbances like nausea, vomiting, muscle cramps, cerebral edema. Don't want those things. Neurons are especially sensitive to excessive water, and death can occur. So here's the story that I always tell when talking about hypotonic hydration. So it's been 10 or 11 years now. Christmas, a radio station in Los Angeles was having a contest that was hold your Wii for a Wii. So this is when we were just, well, they'd been out for a while, but anyway, so the contest was let's win a Wii, and you have to see how many 500 milliliter bottles of water you could drink without going to the bathroom. So eventually this woman in particular had consumed a lot of water, and she hadn't gone to the bathroom, and because of that conscious inhibition of micturation, water was backing up and backing up and backing up and diluting her fluids, and she eventually died of drinking too much water. So we have a lot of things that keep us from doing that. If we were to drink a lot of water at once, we throw up. The stretch receptors in our stomach just kick in and go, you got to stop doing this, and then sometimes make us vomit. So equally bad, dehydration, hypotonic hydration. You know that we're out of homeostasis. It's going to be a bad thing. Okay, so there's that one. We know all of this. What causes ADH to be released? Increasing osmolarity, increasing or osmolality, either one. Sodium concentration in the plasma rises, stimulates the osmoreceptors in the hypothalamus. Remember, I told you these little cells crenate, and then the hypothalamus produces ADH, and then sends it down to the posterior pituitary, that then would cause the release of ADH from the posterior pituitary. That would go to the distal convoluted tubule and the collecting ducts of the kidney tubules to insert sodium potassium pumps in the basolateral membranes, which causes water reabsorption that would result in scant urine, a decrease in osmolality, and an increase in plasma volume because you're causing water to be reabsorbed. Okay. Also, a decreased plasma volume and a drop in blood pressure, 10 to 15%, will cause the baroreceptors in the atrium and the large vessels, the aorta, carotid body, to stimulate the release again of ADH from the posterior pituitary, and then we go down that. And then we have negative feedback. So now that the fluid, extracellular fluid, has become less concentrated, the osmolality is dropped, then the osmoreceptors would be inhibited. The little cells would not crenate anymore, and they wouldn't tell the hypothalamus to produce ADH. Boom. I love this little graphic. This is so excellent. So if I dehydrate, first I'm losing fluid from my extracellular space. Vomiting, I got diarrhea, I'm sweating, hypovolemia, all of that kind of stuff. Well, maybe not hypovolemia, but all those other things. And so now water comes out, ECF osmotic pressure rises, so then the water dumps into the extracellular space from the cells, and then the cells, you lose water by osmosis and the cells shrink. Whereas hypotonic hydration, water enters the extracellular fluid, it's now into the plasma, moves from the plasma into the interstitial fluid, and then moves from the interstitial fluid into the cells, and the cells swell and lyse at worst. Okay. All right. So let's talk about edema and the various ways that you can have edema. So accumulation of fluid in the interstitial space due to either an increase in blood pressure, which makes sense, high hydrostatic pressure, or an increased capillary permeability as an inflammation, or a blockage of lymphatics draining the area. So these are things that we all know. But there's also an edema produced by hypoproteinemia. So this is if I don't have enough protein in my plasma, and so now here I had high hydrostatic pressure or leakage or blockage, but this is, I don't have enough colloid osmotic pressure. I don't have enough albumin. So how do I not have enough albumin? Well, one is, what if I'm not eating enough protein? Then my body doesn't have the amino acids necessary to create albumin. And I don't know how many essential amino acids are actually in albumin. But any time that you don't take in enough of those 7 amino acids that we can't produce inside of our bodies, then you're going to suffer from problems like this. So you could be, if you are a strict vegan too, you have to be real careful if you're going to be a vegan, that you are getting that variety of essential amino acids in your diet, in the plant proteins that you're eating, so that you don't run into this problem. If you have liver disease, obviously your liver is broken and it can't make albumin like it's supposed to. Or you could lose plasma proteins if you had glomerulonephritis, which is inflammatory. So you can have acute glomerulonephritis, which would be, a kidney infection, or you could have autoimmune and glomerulonephritis, where the antibodies will actually attack the filtration membrane. So then that would make the filtration membrane super porous, and we would leak plasma protein. Okay, remember Bowman's capsule is glomerular capsule. I just haven't changed that. Oops. And so now I'm losing plasma proteins into my urine. And remember, what are those 2 things you should never find in your urine? Blood and protein. And then we got, I don't know why I put that in there. Well, from the last one, blockage, removal of lymph vessels. Why do we not want edema? 2 reasons. If we're out in the tissues with the edema, it will impair tissue function. So it'll impair the exchange of nutrients and gases. Waste products can build up, just inflammatory material, dead stuff, just stuff. Yuck. It's like your sewer backing up. You don't want that to happen. And then what if you don't put the water back into circulation? It's going to impair the efficiency of circulation. Your blood is going to become very viscous. The resistance will go up, pressure will go up, and it'll be harder to move your blood. Yes, so Tony just asked, is the term retaining water meaning excess water in the tissues, same effects or cause? Hey, guess what? No. Hormonally, and usually we talk about, oh, I'm retaining water. Okay, that's a hormonal thing, and that is so not even part of any of this. I mean, I guess the actions would be ultimately the same, because how do you retain water like this? I don't know what the hormones are triggering to get you to retain water, but so since we're about to go into reproduction, and we've already had hormone, endocrine system stuff, and I just tell you absolutely everything. So, oh my gosh, I could always tell, and it must have been falling or rising. I don't know. I'm going to think about this before we get into learning about this, since you brought that up. And I would always retain water right before my period, and just like, oh my gosh, I have got to have my period so that I flush this water out of my body. So yeah, here comes what you probably don't need to know. But then when you go into menopause and you don't have a period, then you're just like, you just feel puffy all the time. And oh, it's gross. And so your body, I don't know, maybe that's what's part of being a grandma, and grandmas are squishy, and maybe we're retaining water. I don't know, but that's what makes us squishy, in addition to our, our low metabolism, and we just gain weight anyway. So I don't know, but yeah. So when somebody says I'm retaining water, it's usually a hormonal cause. So, and not one of these. And that probably just went into more than what you wanted to know, but you asked it, I answered it. Okay. So, but it was a good question. Thank you. All right. So now let's talk about electrolyte balance. How are we going to keep our electrolytes where they need to be? So our electrolytes are going to be delivered to us in a salt. Electrolytes are charged particles, ions, and usually they come in the form of sodium bicarbonate. That's what this is, and calcium phosphate. That's not its name, but calcium, I don't know what that is. Some organic chemistry person tell me what that's called. Okay, so why are we worried about being in a balance? Well, it's because our salts can be lost in perspiration. We absolutely know that, in our feces, in our urine. Just as a, FYI kind of thing, there is a disorder called pica where individuals eat substances not considered to be nutrients. So this is like women when they're pregnant want to like eat rocks or dirt or crave weird things. I never craved anything, but when I was teaching with a blackboard, okay, do you guys remember those? Probably not. And I had chalk. I used to like the chalk, to lick the chalk dust off my fingers. I guess that would be like just a tiny little form of pica. But anyway, so pica, a lot of times people go, oh, well, you're just low in some electrolytes or something. No, it's just a weird thing, eating ice, okay? That it's a psychological thing more than it's a physiological thing. It doesn't mean that you need to get more calcium or something, so you're going to go eat some limestone or something like that. So anyway, okay, so as we've already discussed, sodium has the primary role in controlling extracellular fluid volume and water distribution in the body. We absolutely know that. So wherever we want the water to go, we have to get the sodium there first. So it's really important that we look at how does aldosterone play a role in the electrolyte balance. Okay, so here is when aldosterone will get released. Three stimuli for release. One is our electrolyte level. So if I have low sodium or high potassium in my plasma, then that goes to the adrenal cortex, and that will let the adrenal cortex know, hey, guess what? We need some aldosterone. Or, sorry, I'm still trying to drink my breakfast. Or we may trigger the triggering of the renin-angiotensin mechanism, as in low blood pressure situations. Remember, angiotensin 2 is going to stimulate the aldosterone release, because remember, it's the RAAS, so renin-angiotensin-aldosterone system. So once the adrenal cortex releases aldosterone, again, it'll go to the kidney tubules like we just said. Oh, wait, we were doing ADH on the other one, weren't we? And I told you wrong. Right here, I said puts the sodium potassium pumps in basolateral membrane. No, that's for what we're going to do now. No, sorry about that. This is ADH we're talking about. So what are the effects? Collecting ducts, putting the aquaporins in the luminal membrane. So just trying to fix that for those of you that might have been confused. So here with the ADH release, that's the aquaporins in the luminal membrane of the distal convoluted tubule and collecting duct. And then over here, now we're going to put the sodium potassium pumps in the basolateral membrane of the distal convoluted tubule and collecting duct. And what will that cause? So cause sodium reabsorption, right? And then at the same time, if you reabsorb sodium, you will secrete potassium. And you can't have high potassium, high sodium at the same time, because we've already talked about what is bad about having high potassium: hyponatremia, not hyperkalemia, sorry, and you'll get hypopolarization on the inside of the cell because the potassium won't want to come out, and then you'll get spastic paralysis and cardiac arrhythmia, and we don't want that. And so then what will that do? That will restore homeostatic plasma levels of sodium and potassium. And then the water will go with it too. Okay. So we've done this. This is just from a blood pressure standpoint. So this would be a really good thing In fact, this would be a fabulous thing to take a look at again for our test next week on what happens if we have declining blood pressure, blood volume, all of these mechanisms. But you know what, friends? You know every single one of these right now. And I'm proud of you. And I'm excited that you know all of this stuff. Because how long have I been talking about? Wait till April. Well, now we're in April. Now we're learning all this stuff. Okay, so here are hypernatremia. You can read through that. Hyponatremia. It'd be good to just read through it to help you understand more about what's going on. Hyperkalemia, hypokalemia. So here's the funny thing. Look at, we get, whether your potassium is high or your potassium is low, you still get cardiac arrhythmia. So yeah, your potassium levels are really, really important so that you don't have bad effect on the heart. Hyperphosphatemia, hypophosphatemia, not bad because usually we take care of it with calcium levels, so we don't see that. And then chloride, not too much, but anyway, the main ones are sodium and potassium. Those are the electrolytes that are going to really cause us to have major consequences if we have an imbalance of them. Okay, and calcium and magnesium, whatever. I don't care that you know those. All right, so does anybody have any questions then just on fluids and electrolytes? Okay, then let's go into acids and bases. I think you're well introduced into acids and bases now. So this should be just basically a review of what we talked about when I did the ABG information. All right, so remember then that our range for our acid-base homeostasis is 7.35 to 7.45. Okay, now if we were to fall below 7.35 and if we went to 7, so think about on the pH scale, we're still basic, right? Because we're greater than 7.0 or alkaline. However, we call the state of being between 7 and 7.35 physiological acidosis because you are lower than what your normal blood pH should be. So your normal blood pH is alkaline, 7.4. And so anytime we drop below that, we are going into an acidosis state, even though we haven't dropped into the acidic realm of the pH scale. If we were actually to do that, if we were to fall below 7.0, you guys, we would die really fast. So we have to stay in an alkaline state, but not too alkaline. Now, let's take a look at arterial blood has a pH of 7.4, but venous blood and interstitial fluid is 7.35. Who can tell me why the difference? Why arterial blood is 7.4, whereas venous and blood and interstitial fluid is 7.35?
The CO2 concentration is different.
Okay, so tell me more about that, because you're right.
Because after the gas exchange.
Okay, where? Gas exchange where?
In the tissues.
Okay. Okay, no, it doesn't matter. Just pick one and go with it. Okay, so gas exchange in the tissues. So CO2 would be high or low?
It'd be high in the blood returning to the heart.
Okay, so in our interstitial fluid and our venous blood, PCO2 levels are, give me a word.
High.
Okay, and that makes your pH?
Low.
Good, yay, that's exactly what I want. So then we can go to our lungs. So arterial blood has already been at the lungs, right? And so what did we do with the CO2? Anybody? What did we do with the CO2 in our lungs?
Changed it for oxygen.
Exactly. So we got rid of the CO2, and what did the pH then do? Go
Up.
Yay. All right. Okay. So arterial blood should be 7.4 because of a deficit in CO2 compared to PCO2 levels of venous blood and interstitial fluid. Okay. So what I'm going to do for the rest of this whole acid-base stuff is really get you to understand the why. Every step of the way. Why do we get these changes? Why do these things happen like they do? Because we want to see cause and effect. And if you can really grasp the cause and effect, then ABG should be a walk in the park. Instead of just memorizing which way the arrows go, I want you to know the physiology. I want you to understand what's going on. I have a student that's an ER resident in Kingman right now, and his favorite thing when he was in my class was ABGs. And then he went to med school, and then he was doing emergency medicine, and he came back and visited me before he matched, and he said, Miss G, I just want to tell you, ABGs were always the bomb. And he says, I love doing those. When he was in med school, some of his classmates, they're all, how do you know how to do this? When have you done this? Because they went straight bio. They didn't worry about, with nursing people, I guess their anatomy physiology classes didn't have a whole bunch of nursing students in it. Like mine didn't. We just had like med major, pre-med majors in my classes. And so they didn't focus on doing ABGs. And he says, oh yeah, we did ABGs back when I was in community college. And so he was head and shoulders above everybody else. And then he said, I use my ABG information all the time, because in emergency med, here you are, I got a patient that's, I've got some Kussmaul respirations going on. Why is my patient doing that? Why is it breathing fast and heavy? Oh, they're in a diabetic ketoacidosis. And, so then here, get me some labs. Let's take a look and let's do an arterial blood gas and let's see where they're at. So you guys are going to be on the front lines, and you're going to be, like Logan said the other day, this is his nursing members of his family use their ABG information all the time. And you need to know the underlying causes of why you get what you do. So there was a whole little soapbox thing, but just helping you to understand why I'm harping on this stuff for you guys. Okay, so so then a pH above 7.45, of course, is alkalosis or alkalemia. I'm not ever going to use alkalemia. I'm just always going to use alkalosis. And then below 7.35, acidosis. So where do hydrogen ions come from? Byproducts or end products of metabolism, phosphoric acid, lactic acid, ketone bodies, fatty acids, and then from bicarbonate ion formation from carbonic acid. So when I make carbonic acid, of course, I'm going to donate hydrogen ions. Okay. So these are different places where we can become acidic, and truly we're going to be in an acidosis state more than we're going to be in an alkalotic state, just by the nature of what our body's doing. Through metabolism, we generally get acidic metabolites. All right, so what are we going to do then to make sure that our pH doesn't drop below 7.35, doesn't rise above 7.45? Because think about it, you guys, if you were like heavily exercising, you could just really quickly go into metabolic acidosis and go into a coma. Well, that's the extreme, but hey, I don't want to be doing that. I mean, because I like to work out, and so we would hate to have people dropping like flies at the gym because they were constantly going into metabolic acidosis. So we have three mechanisms to prevent the body from rapid fluctuations in pH. And so the first and immediate things that we will have to counteract the change will be our chemical buffers. So these are systems of one or two molecules that are going to act to resist changes in pH by binding to hydrogen ions when pH drops, or releasing hydrogen ions when pH rises. Okay, so if I have a drop in pH, remember I'm too acidic, I have too many hydrogen ions, somebody better come along and grab onto these hydrogen ions, take them out of the solution so that they are not reacting, or they're not reactive anymore. Or when my pH is rising, I gotta bind hydrogen ions to that base to prevent that base from being reactive. So this is a little more complex than what you really need to know, but this just shows, biochemically speaking, what is going on when we're buffering our extracellular fluid, when we're buffering our intracellular fluid. All right, so our bicarbonate buffer system is a mixture of carbonic acid and then sodium bicarbonate in the same solution. So carbonic acid is going to donate hydrogen ions, and sodium bicarbonate will donate bicarbonate ions, okay? And then remember this, let me get my little underliner thing here. Okay, bicarbonate is the only important extracellular fluid buffer, extracellular, plasma, interstitial fluid. So here's what's gonna happen. So let's say that I have some strong acid. Okay, so like this one. What is this? Hydrochloric acid. Okay, so if I combine that with sodium bicarbonate, here's what's going to happen. Hi, no, you're fine. So you're going to take carbonic acid, or you're going to produce carbonic acid, because see, we're going to take this, and this is going to go here, and then this is going to go here, and then I'm going to get a weak acid and sodium chloride. Now, what does it mean by a strong acid? What does it mean by a weak acid? A strong acid is one that completely dissociates in water. A weak acid is one that stays bound, doesn't completely dissociate. So hydrochloric acid, you throw that baby in some water and it's going to completely dissociate. But carbonic acid is going to hang on to its hydrogen ions a little bit more than what hydrochloric acid will do, and therefore the pH will be lowered slightly. Oops, I don't know where that came from. You're still going to get a drop in pH, but not as extreme. Okay, then by the same token, if I were to take a strong base, okay, you're never going to see sodium hydroxide in you unless you drink Drano, and heaven forbid. But let's look at what's going to happen when we're neutralizing this base. Okay, so we're going to take the sodium in the sodium hydroxide. We're going to combine it with the bicarbonate in the carbonic acid, make sodium bicarbonate, that's baking soda. And then we're going to take the hydrogen, we're going to combine it with the hydroxide, combine it with the hydrogen, and then we're going to make water. Sweet. So now I've just made a weak base from a strong base. And so that's what your body's doing all the time. Now, the problem is that if acids enter the blood at such a rate that all of the available bicarbonate, all the alkaline reserves are tied up, the buffer system will not resist pH changes. So we have, at any one time, we have a fixed amount of bicarbonate. And so if that's used up in buffering, then we're going to have to kick in our other systems. Okay. And so then our kidneys would have to kick in to supply more of the bicarbonate. So I don't know why I put that twice. So bicarbonate concentration is regulated by the kidneys. Supply of carbonic acid is limitless due to the CO2 that's being produced by the tissues all the time. So I'm always going to have carbonic acid, but then I've got to take that CO2 and convert it. Remember, I told you that the cells in the proximal convoluted tubule have that one stuff, carbonic anhydrase. And so the kidneys can always produce more bicarbonate, but that's going to take a few minutes, right? And usually it's minutes to hours in order to produce enough by the renal mechanism. And so we have to come up with something intermediate between my chemical buffers kicking in and then the renal mechanism kicking in. So that's the respiratory, and we'll get to that in just a minute. Okay, so all right, so here's how the phosphate buffer works. So remember, phosphate buffers are intracellular. Well, they're also in the urine and the intracellular fluid. Okay, little phosphate is present in the ECF. And so here's the same thing. So I'm just converting from a strong acid to a weak acid or a strong base to a weak base. And then that'll go on in the cell. All right, now proteins on the other hand are both they can be hydrogen acceptors or hydrogen donors. So they can be bases and acids at the same time. So on the carboxyl end of a amino acid, that's why we call it amino acid, it can lose a hydrogen ion. Okay, so there's a proton donor. And then on the amine side of an amino acid, this NH2 group, it can grab on onto an NH3 or onto another hydrogen ion, and then we have ammonia. And we say that proteins are amphoteric because they are an acid and a base at the same time. Okay, so they can donate hydrogen ions, they can accept hydrogen ions. Okay, and hemoglobin is also a great example of an intracellular fluid buffer. Sorry, because remember when in our little making carbonic acid and in releasing releasing oxygen to our tissues that we produce when we're uploading CO2, and then we produce bicarbonate, then we have that hydrogen ion that we need to get rid of. It's going to bind to the hemoglobin, causing the O2 to dissociate from hemoglobin and then go into the tissues. Okay, so great example of protein being a buffer. And protein can be buffer intracellularly, extracellularly, depending on where the proteins are. Okay. All right. So let's just keep going. We're fine. All right. So what if we use up all of our proteins? I mean, all of our chemical buffers? Then we have to kick in a physiological buffer system. So notice it says that they act slower than chemical buffers because it's a process. You're not just binding and being done. You have to do things, and that takes minutes to hours in order for it to happen. So the physiological buffer systems act slower than chemical buffers, but have up to twice the buffering power of all of the chemical buffers combined. Okay, so super, super great at buffering. It just takes a little bit of time. So the fastest physiological buffer system is, of course, the respiratory system. And I was lazy. I wish I had typed that in there. But notice bicarbonate formation equation goes here. So CO2 plus H2O gives you carbonic acid, dissociates into hydrogen ions and bicarbonate ion. Okay, so under normal conditions in healthy individuals, CO2 is expelled from the lungs at the same rate it's formed in the tissues. Okay, and then during CO2 unloading in the lungs, reaction shifts to the left, and eventually hydrogen ion becomes water because when we're CO2, remember CO2 or bicarbonate actually is going to combine with the hydrogen ions again, and then we're going to go back to carbonic acid. So it's this equation going to the left, and then we'll dissociate, or well, it's not a dissociate. Then we'll produce CO2 and water, and then those hydrogen ions, those pesky hydrogen ions that we were worried about, now combine with oxygen to form water. All right, now if we are in a state of hypercapnia, if we are exercising really heavily, for example, we'll get a rise in carbon dioxide levels above normal. That's what hypercapnia means. Medullary chemoreceptors, okay, so they're in the, remember when we were talking about the central chemoreceptors in the medulla oblongata are sensitive to hydrogen ions in the cerebrospinal fluid. But remember, hydrogen ions are not going to cross the blood-brain barrier, but CO2 will. So as CO2, because we're exercising, goes into the cerebrospinal fluid, it's going to go through this reaction, produce hydrogen ions, and then that will stimulate, so those chemoreceptors that will then stimulate the medulla to increase respiratory rate and depth to get you to hyperventilation. So when I produce too much CO2, how do I get rid of it? I want to breathe it out fast and deep. So then as I form this equation, then I'll reverse it with hyperventilation. And then our hydrogen ions, so CO2, remember, is going to cause hyperventilation, increase in CO2. But even rising plasma hydrogen ions will stimulate excessive breathing or hyperventilation. Okay, so the plasma hydrogen ions will stimulate the peripheral chemoreceptors. So this is the central chemoreceptors in your brain. But out in the aorta and in the carotid arteries, we've got the peripheral chemoreceptors, and they also will send signals to the medulla to stimulate deeper, more rapid respirations. So no matter where my pH drops, whether my pH drops in my CSF or if my pH drops in my plasma, I'm still going to hyperventilate. This one's going to kick in first, because then your brain's going to go, oh my gosh, look at all this CO2 and look at all the acid that is forming. You better start breathing fast and deep to get rid of it. But just the support from the peripheral chemoreceptors, that's also going to enhance that hyperventilation to get rid of these hydrogen ions you just produced in your metabolic processes. Like, so think about what's causing us to have metabolic acidosis: starvation and renal failure and diabetic ketoacidosis and alcohol consumption and excessive exercise and all of that. Okay, so we're going to finish this slide and we'll be done. So more CO2 is now removed from the blood, pushing the reaction to the left, reducing the hydrogen ion concentration. So then conversely, when your pH rises, the respiratory rate drops, respiration becomes more shallow. CO2 accumulates, the reaction is pushed to the right, which produces more hydrogen ions, and it lowers your blood pH. So let's think of a time when we would produce, when our blood pH would rise. Well, that would mean that I don't have as much CO2. So when do I not produce as much CO2? When I'm not doing cellular respiration. When does my cellular respiration rate drop, or my metabolic rate drop? When I'm sleeping, when I'm resting. So think about what your breathing rate is like when you rest. It's going to be very, very low because I'm not producing much CO2. My pH is rising. So if I drop my rate and my respiration becomes more shallow, then my CO2 will accumulate, which is what I want. I'll push my reaction to the right, I'll get more hydrogen ions, and then my blood pH will drop. Okay, so here's a really cool thing: doubling. So giving our ventilation twice as much or half as much can change our pH only by 0.2, but guess what? That's all I care about, right? I don't need it. I don't need it to go in a whole 1 of a pH. I just need to go from, 7.5 to 7.3. I don't even want to go that far. So, I don't need to do much changing in my ventilation in order to fix my problems. So remember this, and this will be the last thing that we do. Net carbon dioxide retention leads to respiratory acidosis. Hyperventilation causes net CO2 elimination and respiratory alkalosis. Boom. So that's where we'll stop for today. And does anybody have any questions? So yeah, so what we'll do Friday is we'll finish this off, and we can take all of Monday to just review everything and review ABGs. And I'm just looking at my calendar. We're in good shape. We're in excellent shape, friends. All right. Well, okay, if that's it, then we're gonna go, and I will see you on Friday. Have a great couple days.